Chris Domes from the University of Wisconsin-Madison, and I'm the chairperson for our journal club tonight on patella fractures. Here are our moderators, myself, Dr. Bill Ryan, and Ishvindar Gurwal. Our authors who are going to be with us today are Dr. Egal, Dr. Amir, Dr. Warner has done the video portion, and then Dr. Shodel will be doing our Q&A. Our disclosures are listed. Prior to the live internet activity, all relevant financial relationships have been mitigated. AO staff involved in this educational activity have no financial relationships, and we acknowledge funding done for this educational activity comes from the AO Foundation. AO Foundation receives funding from Synthes. AO North America is an independent nonprofit surgical specialty society dedicated to improving care of patients in musculoskeletal injuries. It does not endorse nor promote the use of any specific product or service or commercial entity. Equipment used in this course is for demonstration and teaching purposes. Here's our agenda. So it's 8 o'clock Eastern now. We'll be going over our videos. Then we will have a Q&A and our wrap up around 9:10, 9:15. Here are the learning objectives, really to review the classic and current journal articles, explain how the literature advances our historically changes our practices, as well as identify best practice. And with that, we will jump into our video section of this webinar. I'm Dr. Chris Domes from University of Wisconsin. I'm joined by Dr. Ken Egel to discuss his paper, Patella Fracture Fixation with Suture and Wire, You Reap What You Sow. Thank you very much, Dr. Egel, for joining me on this webinar and to have a further discussion with our participants after this short video section.
Absolutely. Thanks very much for having me, Chris.
So we'll start off with some basic questions. What made you interested in looking at suture repair for patella fractures, Dr. Egel?
Well, I think, at the time we pursued this paper, options for fixation of these very distal comminuted fractures, especially in the elderly, distal pole fractures of the patella, are very limited. And this was one technique that, had been taught to me as a resident and was kind of a standard. The decision when I was training was either, do a partial patelectomy and advance the patellar tendon versus doing something like this. And it always made sense to me that for a couple of reasons, that you want to maintain the patellar length and not create a patella baja. And number two, that potentially you'd have better healing with bone to bone type of healing rather than tendon to bone healing with suture. So it's kind of something that we started doing. And I think one of the major advantages over time has been the improvement in the non-absorbable, heavily braided suture, which are improved even today over what we originally wrote about.
What changes have you really seen since the almost 10 years since this paper came out, specifically with the suture that you use or your technique? Has that changed?
Yes, it has. I think when we wrote this, we were using mainly Ethibond suture, and we've pretty much switched over to fiberwire type suture now. And now they have even stronger suture tape that's available. In addition, some of the companies have come out with some very sleek and nifty suture anchors that have also been helpful, I think, in reconstruction of the extensor mechanism, both proximally and distally. And so I think those little modifications have helped. I've gone from just utilizing suture alone. I'll use like a hybrid kind of fixation that includes suture through tunnels and an anchor. It's kind of like belt and suspenders. If one fails, maybe you have the other one to maintain fixation during healing.
And in this paper, you showed that between the wire fixation, there was really no difference besides sutures had way less removal of hardware, which is fantastic for our patients. Have you noticed any other changes or complications that do arise in the suture fixation group now that you've been doing this for a lot longer?
Well, when we wrote the paper, we hadn't had any failures, but since then I have had a number of failures. As I've had a number of failures on quad tendon and patellar tendon repairs as well. And usually when that happens, it's a much bigger problem. And although the salvage is a much bigger procedure involving weaving allografts in, um, they actually perform pretty well also. So I think the key, just like any other fracture, is getting the fracture to heal. It's what does the fracture look like at the time of healing? So if you can get those fragments to heal, even if it's a fibrous union and it doesn't look radiographically healed and patient can straight leg raise, then you've achieved your goal.
You have a rehab protocol that you list in the paper, which is essentially weight bearing while keeping the leg straight for the first 6 weeks, and then maybe a progressive bending program after that. Has that changed, or do you still use that same protocol with your current suture fixation?
Well, I'll tell you one thing that I've done when I have someone who I think is really high risk for failure, like a bilateral or again, an older patient, I oftentimes will scrub with one of my sports colleagues and we'll do an acute hamstring harvest, leaving the pes attached um, distally, and we will weave it through, um, the quad proximally, and then tie it down with another anchor on the other side. And when I do that, I feel a little bit more comfortable about letting people move early, even if I don't, and I know that they're gonna, because it's very hard for them unless you cast by both lower extremities and extension. It's very hard to imagine that they're gonna, you know, be reliable in your post-op instructions. So that's one thing that we've done to modify the approach in certain patients.
When you are doing the suture repair, how do you tension the sutures appropriately?
Yeah. So when we're doing a bone-to-bone fixation and we bring the suture through the inferior pole fragments, basically I just look at the lateral radiograph and I'll clamp those fragments, with a pointed reduction clamp like I would if I was going to fix it with cannulated screws, and I'll tie it down, with the bone reduced, and that's usually the guide for, the appropriate amount of tension. The problem is with suture, you don't you only get the amount of tension you get when you tie it down, and then you probably progressively lose a little bit as creep sets into the suture. It's not like a wire where you can keep twisting it and gain more tension, and then it can become a dynamic tension band with flexion of the knee. So they do behave a little bit differently.
One of the things that we worry about with a braided suture in the knee is infection. If you do get an infection, it's a lot harder to find. Any tips or words of wisdom regarding that?
Only spend the time to take it all out. You'll regret it if you don't get it all out. And it's just sitting there with a clamp trying to dig out, undo all of that crack out that you did, and get all the, if you use anchors, make sure you get those anchors out also. It's all foreign material. So you got to get everything out really if you want to manage the FRI.
Even with the suture that we use, patients can be irritated by the knots. Have you found a way, or how do you manage your knots, like weave it through the tendon somehow?
Yeah. So what I'll do is, after we tie them down proximally, I'll leave a length of the of the limbs, and with a free needle, I'll use an 11 blade and cut a little slot in the quad tendon, and then I'll pass the knot through the quad tendon and out the side, and then I'll over sew the little nick that I made to keep the knot buried within the quad tendon. that's better, but if there's any atrophy or anything else, they may feel it. I mean, there's no perfect way to do these unless you use some type of. I've also used sometimes some of these knotless anchors, that you can kind of dunk the suture in by twisting it in, and you end up with a knotless kind of construct.
Dr. Agel, in summary, what do you think people should take away from your research on patellas and including this paper?
So I think obviously we have a very good method of treatment for mid-pole fractures, and even comminuted fractures now with patellar plating has a good answer. But I think that the inferior pole, especially the comminuted fracture in the elderly, remains a fracture of difficulty. And I think the suture technique, utilizing basically the concept of using the patella tendon to gain fixation into the bone, is very similar to what we do with the greater tuberosity in the shoulder. And I think utilizing the suture technique, whether it's through longitudinal drill holes or utilizing suture anchors, with or without any other type of cerclage, patellar cerclage technique as an adjunct, is really the best method for getting alignment of inferior pole patellar fragments and getting the extensor mechanism restored in these complex injuries.
Well, that's fantastic. Thank you so much for taking the time out to do this webinar. Really appreciate and we really appreciate all the work you've done in your research and helping us all be better surgeons. Thank you very much.
Thank you. Thanks very much.
So our next author is someone who needs no introduction. He's been a prolific author in the orthopedic literature. Dr. Mir is the program director at University of South Florida. He's the director of trauma research at Florida Orthopedic Institute in Tampa. Dr. Mir, it's a privilege to speak with you today about the publication on patella fractures treated with cannulated lag screws and fiber wire technique. This paper was published in Injury in February 2020.
Yeah, thanks for having me.
All right, let's jump right into it. Dr. Mir, what do you feel that this paper was needed for in the orthopedic literature?
Yeah, so as a resident in the early 2000s, I had used prior techniques with either K-wires and steel wire tension band, or cannulated screws and steel wire tension band. And then I was a fellow here in 2008 and was introduced to this newer technique, and then used it in my practice the first 5 or 6 years while I was at Vanderbilt. And then came back to Tampa and, was still using it, saw that all my partners here were using it. And after a few more years, figured that it was time to get it in the literature, because one of our fellows who came on board, as we explained it to him, said, "Hey, there's nothing about this out there. I don't think a lot of people are utilizing it, so it'd probably be good to report on it."
That's great. And I'm glad you did. What was the idea behind using fiber wire instead of the 18 gauge? Do you know how that started?
Yeah, so when the product was released initially, there were some biomechanical studies showing that it was, in pure strength, not quite as strong as steel wire, but in cyclic loading and in various loading scenarios, it was equivalent. And then also, with the steel wire, obviously there was a lot of high instance of breakage and implant irritation and problems. So that kind of led folks to areas where they were using steel wire previously to consider using fiber wire.
Awesome. And you had this awesome picture in the paper that really illustrates the technique well. And in my opinion, one of the most difficult parts, which is passing the suture through the cannulated screws. Do you mind just briefly giving the listeners a summary of your technique?
First off, the 4/0 cannulated screws are placed either retrograde or antegrade, depending on the fracture pattern and where it would be best suited. And then with a Keith needle, you'll load a number 2 fiber wire suture. And then, I would suggest testing this on the back table through a regular screw first, because not all manufacturers will allow you to double loop the number 2 fiber wire and actually fit through the screw. So in that case, you have to modify the technique, either go through single stranded or maybe use a fiber tape or something different. So then you'll pass the screw, pass the Keith needle through the screw, starting at the head, coming out of the end of the screw. And then whichever direction you went, you'll want to pass it antegrade or retrograde through the screw in the second screw in the exact same direction, right? So you've passed your suture now, and then here in the second figure, you just cut the needle off, and then you've essentially got two independent tension bands if you wanted. Then in the third figure here, you can see where they're tied. Now, I have tended to not tie these together anymore for knot prominence. I'll actually separate them out and tie them at different corners. And you just have to figure out which end goes to which end, right? And then with the running locking cerclage, this probably doesn't quite represent what I do anymore either. And to avoid bunching things up, I probably make it more of a hexagon or an octagon shape, just grabbing each side a few times and then tying that again at a different corner, not directly in the midline and not directly over quad or patellar tendon. But that way, if you can avoid your knots being prominent, it would be nice. So that's it.
That's a great adjunct for the technique, the fiber wire cerclage. Which fracture patterns did you find that you need to use that?
Yeah, so I actually use it on all my extensor mechanism repairs, right? No matter what technique I'm using, whether it's the screws and fiber wire tension band or a mesh plate, or running suture through like a patellar tendon repair or quad tendon repair, I'll add this cerclage because there's really no downside to it. There's an alternative way you can also do it with doing a running locking suture up through the quad tendon, pass it over the front of the patella and down through the patellar tendon, just to basically make your extensor mechanism one in addition to whatever your direct fracture repair is.
Mm-hmm. That's great. And then, so I saw your paper had quite a few number of patellar fractures. So you looked at a total of 387 patients, and 112 of these patients, or about a third of patients, were treated with this particular technique. Can you describe what are your indications for choosing this technique over other techniques?
Yeah, so if it's a transverse fracture, or maybe transverse with a second fragment that you could fix with an independent interfragmentary screw, like a small 2/7 screw or something, then that's the patterns where I think that this is a good technique. If you have a proximal pole or a distal pole, that's probably mostly an all suture repair type technique. Or if you have a lot of comminution, that's going to be some sort of mesh plate or patellar specific plate technique. So really it's the relatively simple patterns that you would use this on.
Mm-hmm. So you said comminuted fractures and in extreme pole fractures probably would use an alternative technique. Do you have a go-to alternative technique, or
Well, if it's a comminuted fracture, go-to is either a mesh plate or a patellar specific plate. And then for pole fractures, it's mostly an all suture technique.
okay? And looking through the results, you had a very surprisingly high rate of primary union of 97%, and then a low rate of symptomatic implant removal of 8% compared to other techniques in the literature. Were these findings surprising for you?
Not really. That's kind of why we wrote it up, right? Is that we've been doing this for a long time and people were healing and we weren't really taking out much hardware. And so that's kind of wasn't really surprising to find that.
Yeah. And along with that too, your range of motion was great. It was average was 0 to 120 degrees. Can you comment a little bit on your post-op protocol for these patients?
Yeah. So mine specifically, my partners vary a little bit, but they're pretty similar in that for the first 6 weeks, it's active flexion and passive extension only. So we really don't want people firing their quads much. And then when they're standing and walking, it's either a knee immobilizer and they're allowed to weight bear, or for my patients, I use a hinge brace locked in extension. And then when they're seated, they can start moving from 0 to 40 degrees the first couple of weeks. And then after the sutures are out at 2 or 3 weeks, then we advance them 10 degrees weekly. The goal is to be at 90 degrees by 6 weeks.
Excellent. Well, Dr. Mir, I want to thank you for taking time out of your busy schedule to speak with me today. I'm sure I gained a lot from it. I'm sure our listeners also gained a lot from hearing your insight about treating these patients using your technique. So thank you and have a good day.
Yeah, thanks for having me and look forward to the discussion.
Dr. Stephen Warner is an assistant professor of orthopedic surgery at McGovern Medical School at UT Health Houston and works at Memorial Hermann Level 1 Trauma Center. He competed for the United States and National Olympic Rowing Team, and he completed orthopedic surgery at Hospital for Special Surgery in New York, where he co-authored the paper we'll be looking at today with the late Dean Lorich. So the paper we're discussing today is multiplanar fixation for patella fractures using a low-profile mesh plate. So first question, Steve, was really what prompted the idea for this technique? Because it's so far removed from what was previously kind of taught at AO, you know, tension band wiring, cantilever screws. It seems like a really big leap to what you guys started doing.
Yeah, I think Dean Lorich and Dave Helpett were very aware of the poor outcomes associated with traditional fixation constructs for patella fractures with regards to persistent knee pain as well as inferior functional outcomes. And so I think they were really set on finding a solution to that problem. And it seemed like the stability of patella fractures, which are often comminuted, wasn't really addressed with the traditional tension band constructs. And so they sought to be able to develop this new plating technique to address patella fractures, which, as we know, are often associated with comminuted fracture patterns. And the idea with this plate that they developed was able to address the common fracture patterns of comminution with the goal to provide better stability and improve overall patient outcomes. And so that was the premise behind it was, I think, just really realizing, despite our best efforts with some traditional constructs, that patients still didn't do as well as we had hoped.
Cool. And how did the plate positioning and shape evolve? I mean, was this number one technique, or were there some sort of failed attempts previously?
Yeah, so I think they started really with looking at the vascularity of this anatomic location, similar to what they've done in other regions of the hip and the talus. They started kind of with an anatomical study of the vascularity of the patella to look at where the predominant blood supply is, which was inferior medial. And then based upon that, looking at some of the common fracture patterns that are associated with these injuries, specifically with regards to inferior pole comminution. And so taking some of that information with regards to the vascularity as well as the common fracture patterns, then developing what approach may be best for this. And that was the lateral parapatellar approach. And then what kind of implant can be used through that approach to address the common fracture patterns, really to supply adequate fixation to that inferior pole, which is often common and often the place of failure with traditional techniques. And so based upon that, as well as the development of plate designs that allowed for small or mini fragment screw fixation with a high density of screw holes in the plate in a low profile setting, I think really led to that specific plate design and location.
Interesting. So they never went medial then. They did the anatomical study first and then decided the whole time to go lateral. Is that right?
Yeah, so it's a very systematic way to approach it, really taking it from, the first step of looking at the anatomy of this area, then using that to then develop the approach and the method for implant application.
Okay. So just a couple of little nuances from the paper. It said they described not using any tourniquet. Is that still your routine practice to do these tourniquetless? Do you find it makes it reduce it?
Yeah, I'll still use some tourniquets. Depends on the clinical situation as well as the assistance in the operating room. Certainly can be helpful to not use it if there's adequate assistance to be able to visualize the different areas. But I think in this study, as well as in their practice, not using a tourniquet was routine to treat these types of injuries.
And also in the study, they said that at the end of the operation, they range it through a complete range of motion. I mean, I'm brave enough to range my patella fixation to about 90 in the OR. Were they taking it all the way to, like foot heel to the butt, like for flexion?
Yeah, they were aggressive for sure. And I think that's one of the advantages of using this type of fixation is you can have confidence in the ability for this plate with most fracture patterns to be able to stabilize the different injuries. And I think um, one of the main parts of this construct that helps with the stability is obviously not just the plate itself, but the soft tissue repair that can be associated with it. I think it was described in here, the sutures that are applied after the plate has been placed through the limbs of the plate that then get placed with the Krakow suture technique through the patella tendon and then tied back over to the top of the plate. And so that suture augmentation really helps as well with regards to providing stability in addition to obviously the retinacular repair, which we know is also important part of this soft tissue repair.
So yeah, the suture repair interesting because I do that routinely for most of my patella fractures as well. And I was interested, did they have some failures before they did that, before they added that in, or was that straight away off the bat? They just said, we're going to go belt and braces and add that to all our plate fixation.
All I saw was that suture augmentation repair routinely. And I think, again, knowing that this inferior pole has been a problematic part of these fractures and looking at the failure rates and the failure mechanisms without the suture augmentation, even with the cerclage, some of those tension band constructs will often have the cerclage wiring around it just to help support some of the kind of comminution you often get in patella fractures. But even with that, it's challenging to control and stabilize that inferior pole. And so a nice part of that plate is having those limbs going anteriorly over the patella, which then can be used as a post in order to tie those sutures from the patella tendon to offload the forces on that relatively osteoporotic inferior pole that's often found.
And this is just, you may or may not know this, I just noticed looking at the pictures, they always cut out the middle hole. Was there any reason? Was that for prominence, or they just?
Yeah, prominence was one factor. That dorsal part of that, or the anterior part of that plate, is certainly an area that can be, irritating to the soft tissues in that anatomic area, and so that's one of the reasons. And now there are, multiple vendors with different types of anatomic patella plates that are out there, which have kind of fine tuned even further. But the overall idea was to have some limb of those plates coming over anteriorly to provide some multi-planar stability with different screw trajectories that can come lateral to medial, superior to inferior, inferior to superior, and then anterior to posterior. So you have all these different planes available for screws and specific limbs of those plates, which can be applied anteriorly without having as much soft tissue prominence.
So I noticed that you're in the study at the post-operative phase at 4 weeks, it said they were allowing full range of motion without the knee brace. Was that including weight bearing as well, just to let them fly?
Yeah. So weight bearing was allowed immediately after surgery with the kind of isometric exercises to just help with the quad strengthening, prevent atrophy in that early post-operative period. And then 4 weeks, progressive knee range of motion as tolerated. And then at 8 weeks, working on progressive strengthening exercises. So I think, the idea was that added stability from the plate and the suture augmentation really afforded an aggressive rehab protocol, which, the idea was that hopefully that would lead to better clinical outcomes, which it seemed like it did in the further clinical studies compared to more tension band-like constructs.
And how did you choose which patients to try this on initially? Was it just all comers, or were you carefully selected with the initial patients?
Yeah, they were putting them on all comers. They had a kind of a change in practice from tension band to, once they developed this type of construct, to then treat all of them with this construct. And then that allowed a nice cohort comparison to really see if this was a valuable change in implant design, which in the follow-up clinical study, comparing the two different cohorts of tension band constructs to this construct, found pretty big differences in clinical outcomes in these patients, so that provided a nice ability to really see and really test whether this was going to be beneficial for these types of injuries.
So is this still your go-to, or do you use some of the new anatomic plates, or is there still a role for tension band and cantilever screws in your practice?
Yeah, I think it's always good to have lots of different techniques that you can use depending on the patient characteristics, the fracture patterns, and so forth. But certainly, especially for comminuted fractures, this type of design is really beneficial. I think it gives you a tool that can effectively stabilize a comminuted patella fracture that is reliable and has good outcomes. So for sure, used in practice.
I noticed there's some CT scans. Was that routine practice for all patella fractures or just the comminuted ones?
Yeah, for all patella fractures, and one of the kind of lead up studies to developing this was one that showed that around 90% of these fractures had unrecognized inferior pole comminution. As we know, it's sometimes challenging to see the actual fracture lines on a AP knee X-ray of a patella with all the overlying distal femur, and so the CT scans really led to better identification of some of these unrecognized areas of comminution, which was helpful when kind of looking at different ways to stabilize these. And so pretty routinely getting CT scans, and during this course of the study, all patients had CT scans, and I think that led to this a lot of what led to this implant design, as well as just preoperative planning for where the plate could be positioned, what type of screws you may need, what your reduction techniques may be, and so forth.
And in this study, there's only one removal of hardware. In the later ones, was that still fairly low rate of hardware removal?
As far as I saw when I was there, in this area, it's challenging. As you know, it's there's just not a lot of tissue overlying the anterior patella, so I think that's always a concern. And the ability, I think they describe in here, is the in situ bending of the plate as well. Even though there's anatomic plates for patellas, everyone's patella is going to be a little bit different, like other areas of our body. And so the ability to kind of contour the plate with in situ bending irons, I think, is really helpful, so that you can really decrease the prominence of the plate from the soft tissue. And so I think that's one of the utilities of some of the aspects of this technique, as well, is once you have it fixed into place with some initial screws, that you can then contour the plate around the surface of the patella to minimize some of the implant irritation.
Okay, that ends our video portion. Now we're going to be moving to the question and answer. Before that, just a couple things. We have some upcoming journal club, subtroch fractures, MIPO techniques, elbow fractures, and pelvic ring resuscitation. So keep your eyes out for those. These are recorded and made available on YouTube, Spotify, as well as in the Apple Podcast Library, usually about 24 hours after this is completed. So at this time, we'll move on to the discussion. So I'll have my moderators as well as the authors unmute their microphones and join in with their video. I'll stop sharing my screen. So thank you very much to all the authors, as well as the moderators, for taking the time out of your days to come and do this and join this webinar. And thank you very much, participants, for being involved in the AO and checking out these webinars. I think there's a great amount of information that we get from reviewing these journal articles. So we'll start off with some questions, and I'll start off with one to Dr. Eagle as well as Dr. Murr. Are you guys getting CT scans on your patella fractures routinely?
I'm not. Pretty much these are done open, and you have a pretty good view of the entire patella once you open it up and you're looking at it. You flip the fragments down, you flip it down, you can look and you can see everything. So, I go in with a plan and a backup plan and a third plan, and I find a CT scan to not be that helpful to me.
Yeah, same at our center. We do not get CTs on patella fractures.
as Dr. Eagle mentioned, it's a open procedure. You're going to be looking at it. And even if you had a CT that showed a little bit of comminution, you might still try your initial plan before you go to plan B or plan C. And the one situation I could see that is potentially if you're at a center where you're having to call in for different implants for plan B or plan C ahead of time, it might be advantageous. But if you have all of those options available to you on the shelf, I don't see a major advantage in getting a CT scan.
It was mentioned, I believe, with the mesh plate paper, but how are the authors assessing the articular reduction, especially in setting when there's not a large retinacular tear? Are you extending retinacular tear? Are you routinely performing parapatellar arthrotomy?
Yeah, so I'll go first. I do extend the retinacular rent enough to get a couple of small Ragnell retractors and to be able to visualize the articular reduction. It doesn't take a lot to be able to visualize it, but I think that directly seeing it is more reliable than purely going off fluoroscopic imaging because of the odd shape of the patella and the ease with which it can be off.
My experience has been that for the really comminuted ones, the ones I know I'm going to have to plate, the retinaculum is generally intact because those are direct blow fractures causing a stellate pattern as opposed to eccentric load, which pulls everything apart and you have a wide retinacular tear. So those are the ones that I'll do a lateral parapatellar arthrotomy and flip it over and look at it. Especially in a younger person, it really gives you a great view, great exposure. It's just a little weird doing it, but you get used to it.
Yeah, I would agree. I'm not routinely doing a large lateral parapatellar arthrotomy just to be able to look at the articular surface, but obviously depends upon the fracture pattern and what I'm trying to accomplish. I do agree that fluoroscopy sometimes can be difficult to assess. I think it's important to realize that you can get some oblique views. So you're kind of looking tangentially at, the medial and lateral facets. So usually about 20 degrees of internal rotation, 20 degrees of external rotation will kind of get you a view of the medial and lateral articular surfaces of the patella, which can be helpful. But I agree, whether it's something small and get a freer in there or your finger or direct visualization and more aggressive kind of lateral parapatellar arthrotomy and eversion, it just kind of depends upon the fracture pattern and what you need to see and, what you're trying to accomplish.
Is everyone always going lateral parapatellar? Does anyone ever go medial? Has anyone gone medial ever had an issue with AVN?
I've gone medial before. I mean, people do it around the world for arthroplasty, and I don't think all those patellars are dying. So obviously, this is a different situation, and then it's a fracture that's trying to get to heal. But I would think that if there was a real issue with AVN, we'd see a lot of people with total knees with dead patellas.
Yeah, I mean, I tend to do all lateral. I think that's just because I'm a disciple of Dean Lorch. But as Dr. Muir said, I think you could probably go either way, depending upon maybe if that retinacular rent is already kind of created for you immediately. I don't see any reason why you couldn't utilize it.
One question from the audience or the participants is, in patients, and this kind of goes back to what we talked about with Dr. Eagle, with older patients, but patients with Parkinson's disease or neuromuscular disorders who have patella fractures, do you guys have any tips or recommendations for those patients, even in their rehabilitation plans?
So those are ones that on patients who I don't think can reliably weight bear without risk of fall. Those are ones that I'll just make non-weight bearing for a period of time. But I will still, hopefully when seated, allow them to start bending a little bit, but I don't let them weight bear.
I have a couple of heretical views on patella fractures. Number one, I don't think they need to be anatomically perfectly reduced. I think the key is restoring the extensor mechanism, which is much more important because we all have patients with perfect looking x-rays and they still have anterior knee pain. And I have patients who have imperfect x-rays that are doing just fine. And the second is you can lock people up for 6 weeks till they heal and they will get their flexion back. The key is getting extension. If they can't get extension back, that's a much bigger problem. People can't walk if they can't extend their knee. That's what I'm really worried about, especially in old people when I'm not, I have plenty of cases where even screws and tension band wires have pulled out, or the bone is pulled out around that fixation. So I'm much more concerned about getting the extensor mechanism to heal over everything else. That's just my opinion.
We had a couple of questions in the chat regarding either gunshot wounds to the knee or fracture patterns where there's large areas of bone loss. Are there strategies to mitigate this amongst the authors?
Hopes and prayers.
Well, it's interesting. Depending on, when these people come in and who's available and whatnot, for young people, if there's a full thickness cartilage, loss, the consideration is for some type of, graft procedure down the road. And it might be, I've actually spoken to partners about this as the patients come in, calling from the OR saying, hey, I'm in the OR with this really bad patella, young guy, it's all cartilage loss here. And is a potentially a case for a, cartilage transplant or an oats or something like that, and get them involved early. But I think those are the only things you're going to be able to do with that.
Yeah, I mean, not a whole lot to add. I think it's just reconstruct whatever you can. Total patelectomy is a really bad answer. Partial patelectomy is, I used to do, before mesh plating became, more popularized, I used to do partials and they didn't do terribly, but I think save as much of the patella as you can with plating techniques is the way to go.
Yeah, it's interesting. I mean, one of the patella papers that you guys decided not to kind of pick up was, I think it was a JOT article. I don't know when it was, maybe, 10 years ago or so. But I think they actually compared, it might have been Archdeacon's group kind of comparing partial patelectomies to ORIFs, and it actually found pretty similar results, which is kind of surprising. But I agree. I mean, I would try to keep as much as possible, but that's certainly always in the back pocket if necessary.
And Dr. Mir, you talked about using number 2 fiber wire. Is there ever times where you use a thicker fiber wire, like a number 5 or a fiber tape in your constructs?
No, in fact, I'd caution you, sometimes you have to go smaller or go with a bigger screw. So the older 4.0 cannulated screws had a larger inner core diameter, and it was easier to loop a number 2 and get both strands through. But some of the newer 4.0 screws, you can't do it. That's why I said in the video, you need to try that on the back table. You may have to go up to a 4 or 5 screw, or be sure that the manufacturer's inner core diameter will allow you to pass that. So I'd actually caution you to possibly go smaller rather than bigger because of the screw core issue.
There's a question about any consideration of periprosthetic patella fractures in knee replacements. Anyone do anything differently?
It's a different animal because, you've had this, it's a very thin patella. It's been avascular at some point because of surgery and cement, likely. I think it's just a different animal. We do, again, if you can get it to heal fibrously, it'll probably work fine. These are the cases where the arthroplasty people have been doing these entire extensor mechanism allografts sometimes for people because they're very difficult to get to heal. And those people who end up needing that end up doing marginally.
I'm at an institution where fortunately my arthroplasty partners do not resurface the patella. So at least for a lot of these periprosthetic extensor mechanism disruptions, whether it's, the quadriceps or patellar tendon or patella fracture, at least I have a whole patella to work with. And so, obviously you can't influence them to do what they want to do with the patella, but obviously it really makes life a lot easier when that's the case.
Yeah, even easier. I have partners who are dual fellowship trained in trauma and arthroplasty, and pass it on to them.
Even easier.
And Dr. Eagle, what suture anchors are you using, or what size of suture anchors are you using when you're using those to supplement your patellar fixation?
I think they're 4 or 5 anchors. I don't know if you want me to use name brands or whatever, but
just size relative.
Yeah, that's what the anchor is. And I generally use like either a number. You can get a number 5 through that anchor, or you can use 2s also.
There's been a couple questions about how to prevent, Dr. Muir, your screws from cutting your fiber wire. Any tips or what have you found to prevent that from happening?
Yeah, so it's the same technique as if you're using steel gauge wire through the cannulated screws, right? Your screw, the end of your screw needs to not go past the cortex on the far side of the patella, right? So it's got to stop short of the cortex. And then especially even with steel gauge wire, but even with a suture technique, as you're taking the Keith needle through the end of the screw, it's not coming out right at the edge of the screw, right? It can go up through the quad tendon a little bit before it comes out, or if you're coming the opposite way, through the patellar tendon a little bit. So there will be a little soft tissue cushion in between when you tie the suture down to protect it from the screw as well. But really, it's the key is making sure the screw is not protruding out past the end of the patella.
And what value do our authors put on the, not so much the patellar fixation portion, but the retinacular repair portion of the case specifically? Do you guys find that to be as important as the osseous actual fixation? Is it less important? And what might you use, or what do you guys personally use to close the retinaculum specifically?
I mean, the fact is, I don't know how important it is, because after the skin is closed and the patient heals, I don't know what that contributed to it. And if there's a failure and I go back, oftentimes the retinaculum can be intact, or it can be, retorn. And I don't know if it's because the sutures failed initially or they failed eventually. So I can't really answer that.
Although it does make me feel good to repair it. I usually use just number 2 fiber wire and just try to get as much tissue kind of together as I can. Again, I don't know how much it contributes to the overall kind of stability or strength of the construct, but I'm just kind of throwing as much as I can together, and hopefully just some scar will help.
Yeah, I do the same. I do interrupted figure of 8s on each side to repair the retinaculum. And then something else I do is for every extensor mechanism repair, patellar fractures we're talking about tonight, but whatever I'm doing, I get a flexed lateral in the OR with the knee flexed at about 90 degrees to show that my construct was stable in the OR. And then, I don't let them bend to 90 initially on my post-op rehab protocol, but just to show that I could get them there. And if I can't get them anywhere close to 90 with what I've done, then I question what I've done, especially on an acute setting. Revision, maybe I'll cut back a little to 70 or 60, but on an acute setting, if my repair can't tolerate 90, then I question my repair.
Yeah, I think one of the questions that I had previously asked Dr. Eagle is in the suture repair, it's a little bit less gratifying to do that post fixation, post stabilization bend test, because you'll see some gapping with the suture itself, and that can be a little bit more gut wrenching. So I do go to 90 just to prove to myself that I can, but Dr. Eagle, I think in our discussion, you said you generally go to around 30 or 40, just make sure it can definitely tolerate that, be as compared to going to 90 with just the pure suture repair technique.
Yeah, if I use a cannulated screw wire technique, I usually get good fixation, and you can let people move. But when you're using all suture technique, I think it's you're asking a lot of the suture and the patient and whatnot. So I'll at least get 30 to 40 just to make sure that it's going to withstand something. But then I'll probably hold them and not let them bend for the first 6 weeks.
Harry, the mesh plate is flexed all the way up in the OR. Going over Dr. Warner.
That seems a little aggressive. There's also a lot of aggressive things that Dr. Lord seemed to do, like all his plateaus he put on a CPM post-op day 1 and wouldn't let him leave until they reached 90 degrees, which I do not do. And so, yeah, I certainly do not do that whenever I'm plating a more comminuted fracture. I mean, I think it's probably stable enough, like you said, to flex to 90 degrees, but I'm certainly not trying to touch their heel to their buttocks. I think that's a little much.
I know all the authors presented low rates of hardware removal in their papers, but what is the earliest that you consider hardware removal?
I try to get them to 6 months if possible. You know, not based on probably really any hard evidence or data, but I try to get them to 6 months if I can.
Yeah, I think longer the better, but you know, try to have, yeah, exactly. I agree. Some sort of threshold of 6 months if I can get them there.
Yeah, I usually tell people at the very beginning that we can't take the hardware out before a year, because I figure if they have that in their head, they won't even bother me. And then maybe by then they'll forget about it or something else will bother them.
And are any of our authors or even our moderators, is anybody still using 18 gauge wire in their practice?
Yep,
I am.
all the time. I use 20 gauge because the 18 doesn't fit through the cannulated screws as well.
I'm Tampa trained to know.
Any technique or tips for using wire as compared to suture, since it's a little bit more challenging to work with, just harder, and you got to really make sure you tension it not without breaking it too many times?
I don't know. Personally, I find it easier to pass through the cannulated screws than pass the suture. So, and you know, everything is just what you're used to, and you know, experience. You know, the more you do it, the more facile you become with it. So I've never really had a problem using the wire, and I prefer it because of the fact that I can tension it to my desired tension.
Are you making them keep their broken wires in for a year?
I don't have many broken wires. I used to have a lot of broken wires when I just used K-wire and the tension band, but now that I use the cannulated screws, I don't see really any broken wires.
Yeah. No, it's definitely different, I think, with the screws than with the K-wires. Yeah.
Is anybody still using K wires as compared to screws?
I do occasionally. I mean, I think all these techniques are good to be familiar with and have in your back pocket, you know, depending upon the fracture pattern and the patient. And I do. I actually find that to be relatively simple. I mean, the hardware is more prominent. I think the hardware removal rate is probably a little bit higher. So I tend to try not to do that, but I still think there's a role for it. And I'm, you know, more than comfortable doing it. Just did one, in fact, last week.
There's one trick I've found, if people have access to it, is actually having your 18 gauge wire, your 20 gauge wire on a sternal needle. It allows you to pass it very simply, as it's attached to generally a very large caliber needle. So you can pretty easily pass that under your wires through your tendinous portion. Just a little trick I learned in fellowship. And with
So am I allowed to ask a question? I'll ask the question. Is what cases are you using K-wires and steel wire on? Like what patient is that shows up that you think that's the right answer?
Resident education. I think if they say that they want to try something different, just because they've seen plating, they've seen cannulated screws, and they want to try to, you know, more kind of traditional, you know, modified tension band with K wires. I mean, I'm fine doing it. So I think it's, again, I don't think it's a particular pattern as it gets become more distal pole comminution or just more kind of multi-fragmentary. Obviously, I'm going to probably advocate against that, but for some of the more simple transverse fractures, I think it's totally acceptable. So I don't have a particular patient where I say the wires are better than the screws, because I don't think they are, but I think they do a good job. And I think you know, it's interesting to kind of point out. I know Lorich I wasn't an author with him on this, but you know, probably 10 years ago or so, he did a meta-analysis looking at, I don't know, maybe 10 to 20 papers, maybe 500 to 700 patella fractures using various different techniques. And I think their non-union rate was, you know, maybe 2%. I mean, these patella fractures in general have a relatively low non-union rate. Now, the reoperation rate was high, obviously, just because of hardware prominence and need for removal. But, you know, for the most part, I think if you do a good job with whatever you're using and obviously, you know, kind of backing up with some of your soft tissue repair, I mean, these are going to heal. And as Dr. Eagles kind of pointed out, I think as long as you kind of restore that extensor mechanism, patients overall are going to do relatively well. But yeah, I don't have a specific patient that I kind of go with the old school kind of, you know, modified tension band K-wire technique. But I think just kind of whenever we want to mix it up.
Sometimes I'll use a K-wire, like if there's a mostly transverse fracture that I fix with a couple of cannulated screws, and then there's a little fragment on the corner or on the edge somewhere that needs to, just to make the X-ray look better, to fix it in with a K-wire if we don't have like a small screw or it's too small for some type of screw, and then just, bury it.
I do like it just because then the cerclage wire is kind of passing over the superior pole as well as the inferior pole of the patella. So I feel like it's doing kind of a better job of kind of capturing the patella. Again, it doesn't matter. I don't think. It's just, sometimes I think it's useful.
Dr. Regal, how often are you leaving the cut-off wires in? So I used to do that, but now I try to use the absorbable pins instead.
I'm sorry, I'm
How
sorry.
often, if you find that little bit of comminution, you're just going to cut a K-wire off and leave it there? I try to use the PLLA pins now instead.
Yeah, I do it rarely, and if I do it, what I'll end up doing is, I'll put it in, I'll back it out, I'll bend it over like to 90, and then I'll pound it in so that it kind of, like almost like an olecranon,
Okay.
less chance of it backing out and also less chance of it advancing. So,
Okay, so you're not just cutting it flush with the.
no, I mean, I would do that if I was using threaded K wires, but just in case you needed to get it out or whatever, I want to have some way of getting it out, I think.
And has anybody had any experience where you're passing your cannulated screws, or you're doing your tensioning and you get some added comminution once you're doing that, or you start getting pull out of your screws or poor bone quality?
Yes.
What do you do? Plan B,
I-
plan C.
I would tell you, anytime you're operating on an older person, poor quality bone, just be prepared. You don't need a CT. That thing is going to be more, it's never going to be two pieces. It's always going to be more comminuted than you think. The articular surface will be separated from the dorsal cortex. Everything that you can think of possibly expected in that case. And, be prepared for plan B and plan C, that's all I can tell you. But just get the extension mechanism fixed any way you can.
Yeah, I mean, I've certainly had cases where plan A was screws and then we converted to plating.
How much comminution are you accepting and still doing screws? Because I find that sometimes I go in with a plan to plate it, there's one little piece, I'll leave it, like I'll put a wire on a pin or something. But then what point you said, no, okay, I need to bail out, I need to plate this?
So for me, it's if there's a little bit of dorsal comminution that I know will get captured under the sutures, I'm not too worried about that. And if the screws are still through the good cancellous bone on the articular side, but if the screws have just purely gone through fracture and they're not actually supporting the articular fragment or capturing the articular fragment, that's when I'm going to bail to a different technique.
And when you guys are doing your plating of patellas, are you frequently using a higher proportion of locking screws or cortical screws, or giving it kind of what it needs to get that fragment specific fixation to those smaller comminuted pieces?
I think kind of depends upon the patient's bone quality, but I pretty much err on, cortical screws initially just to help kind of, push the plate down to make it, a little less prominent. And then, depending upon, again, bone quality, fragments, where I'm trying to get screws, then I could switch to some of these variable angle locking screws or just regular locking screws. But for the most part, cortical screws, I think, are typically pretty fine or adequate in the patella.
Yeah, I tend to use locking screws because these are going to all be unicortical screws. And I'm always worried about unicortical non-locking screw back out, especially that's when it's under tension and such. So I'll almost entirely use lock. Once I get, I'll get the plate sucked down with a screw and make sure it's well contoured. And then pretty much all locking screws, except if there's a chance to put one vertically through, a bent over portion of the plate.
I think in the A to P screws, like you said, unicortically, and then having the screw head sit a little more flush with the plate and be less prominent is good. But, some of the more peripheral rim screws you're kind of shooting across can be bicortical. And I think usually those can be Cortex screws.
Yeah, same, nothing different.
And are people still making their own mesh plates, or is anyone using the anatomic plates out from the various companies? because the mesh plate goes around the lateral rim, but most of the anatomic ones are completely different. They're on the dorsal surface and going from inferior to superior.
Yeah, I mean, for highly accommodated ones, I'm using the anatomic anatomic plates now. For ones that are kind of variants where there's specific areas of combination, that's when I'll tend to use a plate that I can shape myself to be more fragment specific for that case.
Yeah, I've kind of moved more towards some of the pre-contoured plates just because it's just, I don't know, a little bit easier. And, you know, when we were using this technique, there was nothing out there, and now there is something to use. And for the most part, it seems to work most of the time, depending again, you know, how much of the kind of the peripheral rim I need.
And Dr. Murray, you were talking about using a barb suture as an augment to kind of your retinacular or circumferential repair. Can you describe that or how you do that?
No, I
in your
don't. I personally actually don't use any barb suture. Ishii is laughing because he was my fellow and I yelled at him for using barb suture. But yeah, so I don't use barb suture. I'll just do a running locking. I typically do that with a fiber tape now rather than a fiber wire, just for something a little more robust, but just a running locking cerclage.
Well, I think we're going to actually end up wrapping up this webinar and this Q&A section. But once again, I want to really thank all of the authors as well as the moderators, and then also our participants. Thank you so much for joining us tonight, and thank you for being involved in the AO, and we look forward to seeing you again. And thank you to our AO staff as well for their excellent help, and thanks everybody.